Kurian. They'll be joined by guest experts to discuss an array of newsworthy medical and health issues. You're invited to ask the doctors anything. The physicians and their guests' views are their own and do not represent any institution. Please contact your doctor for any personal questions. Please hit share and join us live on Facebook, Twitter, and YouTube at She's On Call, hashtag She's On Call. Please welcome our hosts.
Hi, I'm Dr. Sujana Chandrasekhar. I'm an ear, nose, and throat surgeon, and I practice with ENT and Allergy Associates in New York and New Jersey.
And I'm Marina Kurian, and I'm a general surgeon, and I work in New York City and have a few offices around the boroughs.
We are happy to welcome you to our 5th show of She's On Call. We've had 15,000 views so far. Please share and like and tell your friends to join us because I think today's just going to be a terrific show. We have 2 guests. Dr. Susmita Pati is Professor of Pediatrics and Chief of the Division of Primary Care Pediatrics at Stony Brook University in Long Island, New York, and the Chief Medical Program Advisor at the Alan Alda Center for Communicating Science.
And our other guest is Dr. Quinn Capers IV. He's a professor of medicine and interventional cardiologist and vice dean of faculty at the Ohio State University Medical School. And we're going to be talking to them about pediatrics and cardiology and when should school opens, what kind of strategies can we have, as well as talking about some of their efforts in not just communicating, but also in diversity amongst our medical schools and our faculty at these different centers. Dr. Capers and Dr. Patti are waiting in our virtual green room, but first, Sujana and I are going to talk a little bit about the news of the day.
So Marina, it's getting kind of old, but we continue to see an alarming increase in COVID-19 cases and deaths in certain parts of the world and certain parts of our country. The world is up to 12.4 million cases, and the US is up to over 3 million of those cases. Almost 600,000 people in the world and 136,000 people in the US have died from this disease so far. I know that they discussed the situation in Brazil yesterday on Sri Srinivasan's COVID series, but they have nearly 2 million confirmed cases and 70,000 deaths. And India has nearly 800,000 confirmed cases and 22,000 deaths. So this is a huge problem that continues.
Yeah, 100%. I mean, we really haven't created the best strategy yet, except maybe in New York and in the tri-state we should pull that slide up of what we're doing. But I think that, wearing a mask is still important. I know we keep saying that. And I think that testing is important, contact tracing is important. And what we're seeing here on this slide is in the green, or sage, as I like to call that color. 12 states are meeting the testing target for the population of their state so that we can accurately look at what the incidence of the virus is. 5 states are getting near, but unfortunately 34 of them are not really anywhere near the target, and that's like the red zone. So the importance of that really is one, identifying the incidence and decreasing risk of transmission, because the people who test positive then can self-quarantine and then get tested again, and decrease the risk of them infecting other people. Because remember, everyone, it's not when you're sick and coughing and that you're at the worst risk of transmitting. It's when you're pre-symptomatic, when you don't have any symptoms, and you can be highly infectious at that time.
Yeah, I think, we've shown the slide of how to wear a mask properly before. I walked through Rockefeller Center on many days, and even the statue of Prometheus over there is wearing a mask, as you can see. When you wear a mask, and please wear a mask when you're not with people you live with, it has to cover your nose to under your chin. Masks under the nose or above the chin don't provide protection from viral particles getting out. The states that have done really well after horrible times, New York, New Jersey, and Connecticut, have actually issued quarantine warnings for 16 or more other states in the United States, which are now hotspots. So if you're traveling from those states up to what we call the tri-state area here, please make sure you stay quarantined, you check your temperature, and you only interact with other people after 2 weeks. So we know that you're not going to bring the disease back. We've just had a very rough go of it up here for the last 3-4 months, and we'd like not to do that again.
Yeah, I think it is important to practice all of the usual things that we've been saying. Hand hygiene, as a last slide showed, and wearing the mask and trying not to touch your eyes, nose, and mouth. And, you know, I had this great discussion with a patient who came in, and the MA had seen him before I did. And she had told him, because he came in with gloves, she said, you know, the gloves aren't necessarily going to protect you because you think you're safer. And he was like, what does that mean? And I said, well, because when you have the gloves on, you think you would touch more things than if you didn't have the gloves on. And then people who are wearing gloves are still touching their eyes and their nose and their mouth area, even, or touching their mask, and it's not the right thing to do. So sometimes, like, I don't wear gloves when I'm out and about. Obviously, when I'm operating or I'm at the hospital seeing patients, I'm putting gloves on, or in my office, I have gloves on. But when I'm out and about, I don't. I just have Purell with me, and I just frequently use it. And I also try not to touch a lot of surfaces.
Yeah, I'll tell you, we can keep talking about this, but I hope you guys all get the message. There is a new piece of news. There was a study that came out that looked at people on proton pump inhibitors, PPIs, which are used very commonly for reflux disease, for heartburn. And it looks like there is a higher chance of contracting COVID for people who are on the PPIs twice a day, which is the green bar, and even on them once a day, which is the orange bar, unless compared to people who are not on them. There are other types of antacids, like the H2 receptor antagonists, and please feel free to take a picture of this slide to just kind of go over it yourself later. We're not advocating getting off of medications that you need, but we are suggesting that you consider dietary modification, low acid diets, things. Talk to your doctor about different ways that you can try to avoid medications that you may not need if you can function without them. As an ENT, we see people with voice changes from gastroesophageal reflux disease or GERD all the time, and I think a lot of us talk to them about trying to maintain low acid diets, healthier eating habits, so that we can keep them off medications as much as we can.
You know, you and I had a little bit different takes on this study. My concern, you know, and I think everyone who sees these studies come out in the press is like, well, that's what you say today. But last week, there was another study that showed something different. But this particular study is the first time that they're looking solely at these proton pump inhibitors, which are given for GERD. As well, there is data showing that if you're on an H2 blocker, which is the pepsids or the famotidines or Zantac, ranitidines, that they are not going to increase your risk. The interesting thing about this study, though, is that even though the patients who are on the PPIs, and that's like omeprazole, Prilosec, Nexium, all of those, even though they were on those and they seem to have a higher risk of contracting, that their GI symptoms were much less in that study. So it's tough to say if the only thing that's helping you is the proton pump inhibitor in terms of managing your GERD and reflux and burning that many patients suffer from. It's hard to say to stop it. It's just another piece of evidence that we're getting from all the studies that are coming out right now as we see patients across the different centers and states. And I think it's just something added. But, you know, I think exercise some caution, bring it up with your doctor. It was a decent sized study. There were about 3,300 patients in it out of a larger cohort of like 55,000. But I think, you know, just it's still observational. And so, you know, there are a lot of other factors that happen, but this seemed to trend toward this was a significant finding.
So, you know, I think this goes to why you and I decided to start this show, right, Marina? I mean, we were really appalled by some of the misinformation that was coming out of medical things, especially during the COVID pandemic, but certainly even before then. And part of why Marina and I decided to start this show was in order to give you guys a sense of the multi-nuanced approach that physicians, healthcare workers really take to reading the literature, putting it into context, reading other literature, and trying to give our patients and our communities the best advice that we can. So with that segue, I think it's a great time to introduce our guests. As we said at the top of the hour, we have two wonderful guests with us today. Dr. Susmita Pati is a pediatrician. She's professor of pediatrics and chief of the Division of Primary Care Pediatrics at Stony Brook University. She's also the chief medical program advisor at the Alan Alda Center for Communicating Science.
Thank you so much for having me.
Welcome aboard, Susmita.
Yeah, we're excited. And then Dr. Quinn Capers, the fourth, he's professor of medicine, and he's an interventional cardiologist, vice dean of faculty at the Ohio State University Medical School. And welcome, thanks for joining us. You know, I play fantasy football, although right now we got nothing, right? But so I've always loved when the players come on and they're like the Ohio State. So whenever I have guests on, even my radio show, I love to say it like that because it just, you know, it's fun.
Well, thank you so much. In fact, I was going to give you an A+ for the way you said that. So we're proud of that. So thank you very much for having me. I'm really happy to be here. Now, I remember, Sujana, when you reached out to me, you said, I hope this is still the case, that I would be the first male that you had on the show. If that's true, you know, I love those bragging rights. I'm going to take those bragging rights, and I'm very, very proud to join you today for a good discussion.
You know, we're not trying to be an all-female show. We are happy to have you, but someone has to be the first. So there you go. you're a tag.
and I have to say, when we've all been the first woman, we've always been overqualified to be on the panel or on the session. Mm-hmm. So just like that, Quinn, you are kind of overqualified to be here. So we're very, very happy to greet you.
Thank you. Thank you.
That's some great he for she right there.
So I know that Susmita, you must be calling in from Long Island, and I wonder how things are going. How's life out there, and kind of give us a flavor of who you are. How'd you decide that being a doctor was it for you?
Yeah, sure. Happy to talk about that. You know, I am the proud daughter of immigrants from India. I grew up in Connecticut. And as I went through K through 12 there, I was in public school, and I had thought about becoming a doctor, but I really wasn't sure. I went off to college at Harvard and did biochemistry there. And I quickly learned that this kind of thing, that wet bench research, was not my cup of tea. And then I went back to my home state, the University of Connecticut, for medical school. And that was actually one of the best decisions I've ever made. I got that in-state tuition benefit. It was a real boon. And during that time, I had the opportunity to go to Puerto Rico and do a project where I was interviewing families about food security and comparing that to families who migrated to the Hartford area. And I really like that kind of research, much more clinically, population, patient-centered. And that's really where I started, you know, my medical career. And here in Long Island now, just, you know, where we've been at, just like you all have been in New York City, sort of at the epicenter, Long Island has also been hit hard. More westward than eastward, and that gave us a little bit of time to sort of prepare here on Long Island. And we actually had the benefit of the FEMA folks putting up tents for emergency hospitals on our campus, on the other side of campus. But, you know, things are going okay. We've sort of, you know, been reopening slowly, and all of our patients are coming in, and children getting their well checkups and their vaccines, which is, you know, a really big deal and so important for everybody's health.
Quinn, how about you? What's sort of your background? How did you kind of step into medicine, if you will?
Thank you. So I really never wanted to be anything else other than a doctor. So I'm living my dream, and every day I feel like it's a blessing because my dream came true. So I grew up in Dayton, Ohio. Always wanted to be a doctor. College, went to Howard University, and that was Howard University is one of the premier historically Black colleges and universities. It's in Washington, D.C. It just fit everything that I wanted in a college. And was probably one of the best decisions that I've made in my life. So from Howard University, I, like Susmita, I came back to my home state, to Ohio State University for medical school, and then did my training at Emory in Atlanta. So to the answer to the question of why I wanted to be a doctor, to this day, I don't know. I just say, God put that on my heart. But I always, in addition, had a very keen sense of racial injustice and a desire to want to be kind of a champion for racial justice. And so for me, medicine and these two things go together quite naturally. So I love interventional cardiology. I was doing my training, and in my training, it's when it really cemented on me what I felt was one of my very few missions that will drive me until the day I die. It was one weekend that I was on call, and I did my training at a medical center that had multiple hospitals, which was a very good way to train. And I still think that's a good way to train. There was a VA hospital. There was the university hospital with very high risk tertiary cases, but really caters to the well-heeled. Everybody has insurance. There was a county hospital that took care of all the poor people. And one weekend, as the fellow, you had to cover all these places. And so one day I was at the VA hospital, and a white male came in having a heart attack, and the VA didn't have an after-hours cath lab. In that system, the university hospital was the only one with an after-hour cath lab. And so I called my attending, who was backing me up, and he said, well, we got to get him out of there, get him to the university hospital so he can have an emergent coronary angioplasty to open up the artery and stop the heart attack. The very next night, I was at the county hospital, and it really was the same scenario. A Black man, uninsured, came in having a heart attack. And this county hospital also didn't have after-hour cath lab, but we were affiliated with the university hospital. And when I called the attending to back me up, the answer was, well, we don't really do that here. So just give him lytic therapy, which is the medication used to treat a heart attack, which is inferior to direct angioplasty. And so I've seen in one weekend 2 people with the exact same scenario get different levels of treatment. And that really bothered me. And so I think about that even now as I teach, as I do research, as I write, and as I treat my patients. So those are some of my motivating factors. Here in Ohio, we're doing okay. I really give a lot of credit to our governor. He was one of the first governors to put in a shelter-in-place order. And as a result, Ohio, we never really reached, and particularly in Columbus, never really reached the number of cases of COVID that the models had predicted we would. We kind of hit our peak, and fingers crossed there won't be a second peak, kind of late April. At the Ohio State University Medical Center, our cases are down, although statewide cases are starting to go up. We have to be smart. We have to do everything we know. And so far, the only thing we've done that really put a dent in this was social distancing, wearing masks, and as we've already talked about, doing things like not touching your face, which, by the way, I'll say on Zoom, I've noticed now that I have so many Zoom meetings that I'm really big about, I do a lot of touching my face. So I had to try to retrain myself to tell myself, Quinn, don't do that.
We discovered a lot about ourselves looking at ourselves on these horrible little screens, right?
Yes.
I have to say, one of our stalwart fans, J.H. Kim, wrote in racial injustice. Let's see, she had a beautiful way she put it. She said, civil justice, racial injustice, and interventional cardiology is vital for our high-risk demographics. And I think I think Quinn, you said that really well. I think Susmita, you said that really well. I think it's funny, we never thought about it when we went into medicine, but we can be and are, for the most part, social justice warriors, either in our own institutions or more globally. And I think it's an amazing side effect of all of those years of education, all those years when we couldn't go out with our friends because we were studying. And I think it's all worth it. You know, Susmita, you had talked about kids are coming in for their routine well child visits and their vaccinations. And I wonder if you can talk to what pediatricians and pediatrician offices are doing to make that safe. And I know I've gotten a lot of questions about all this screen time when schools were closed for the past few months of school, and on top of that, gaming. So maybe you can talk about how we should guide our children in terms of getting them to the doctor for care and also counseling them about screen time.
Sure. There's a lot of information out there. So let me just say, you know, we want to make sure we're always following the guidance that we get from our scientific advisory groups. That includes, of course, the CDC, as well as the American Academy of Pediatrics. And then, you know, the governors are putting out their recommendations as well. And so they have done that for healthcare settings in terms of the protections that should be worn by healthcare workers, as well as the precautions that should be taken by all the staff and the screenings that should happen for all the patients and other people who may be coming into the office. So of course the masks, that's the same thing that we're all doing as we go out and about, whether you go grocery shopping or to the pharmacy, those kinds of things. And for healthcare workers, the guidance is also that we need to be wearing goggles, eye protection as we're seeing patients in the office. And then it kind of goes up from there, depending on whether you're in a surgical setting or an inpatient setting, whether you're taking care of patients with coronavirus or not, known or not. So there's a lot of precautions that are being taken and a lot of screening that's happening in many healthcare settings to ask, for example, the parents or the guardian who's bringing in the child for their checkup. There's multiple time points at which people are asked, have you been exposed? Do you have any symptoms? All of those kinds of things to prevent that spread from happening. So it's very important to get vaccines for your children. At the same time, if you or your family member who's taking your child into the doctor is not feeling well, it can wait until you're feeling better. So, those are the general kinds of things that the guidelines that are out there for, how to keep things safe. And I do think what we're hearing more and more, during this whole pandemic, there were childcare and daycare centers that were open to take care of the children of essential workers like all of us, as well as other frontline workers. And those centers had to take all of these precautions. And what we're hearing from those studies is that there's not a lot of infection happening from those centers. So that, to me, is reassuring that these measures work if we take them.
I want to
So
go back to this for a
that
second.
graphic that we just put up was actually of a pediatric dentist in Manhattan, Ruby Gelman, and this is how she's geared up to see her patients. And I asked her, are the kids afraid? And I think you're right, Dr. Pati. I think that children really seem to get it and to understand that all of these precautions are being taken for them.
I think they do. I think, it's certainly not the same as, not having all that stuff. As pediatricians, a lot of us went into this field because we like to play. And so we can make it a game, when we're in there with the children, pretend to be a superhero and they kind of get that and they play along with you, which is a lot of fun. So, it's been challenging, of course. And, all of us went into this to help people. So that's what we're doing.
So I just wanted to go back a little bit to what we had said about, the social and racial inequities in our healthcare system. And I just wanted to, when we were talking about it, I really wanted to point out this is actually a global phenomenon. I mean, people, even in countries that have socialized medicine, there's a private system. So if you, pay for play, you can get in sooner. And so I don't think, while I think it's dreadful in many areas. Actually, when I trained, Quinn, I did not train at a county hospital. We didn't have that. I trained up in Albany, but I did have the VA, loved the vets. We had a community hospital and then our tertiary care. But I do see that the county hospitals, people who work there really, from all the healthcare providers and the doctors, they really do try to deliver the best care. In New York, am affiliated with Bellevue. I don't actually go there very often at all. I have great colleagues that do, and I know that they are always trying to do the best care that they can. But when you train, perhaps in the county hospital, it might have been a little bit different scenario. And I'm hoping with your efforts that you've actually seen that change over these past 10 years, maybe, Quinn? I'm not sure. And then I want you to answer that, but I also want you to tell us what's been happening in the ER, because you know what, all of my colleagues across the country, and I do general surgery and minimally invasive surgery, are like, they're going, where are the gallbladders and the appendix? And then what happens is they come in very sick, or their primary care doctors already started them, certainly for appendicitis, on antibiotics at home, so that when the patients are still sick and they come in, they have much more complicated disease. And we're seeing, a greater colon resection. It's a lot more, rather than catching something early. So I can imagine with cardiology, initially everyone was like, where are all the chest pain patients? So just let us know what's going on where you are.
Well, so thank you. So you're absolutely right. The nationally, interventional cardiologists started talking about this so interventional cardiology is a specialty that we treat the heart attack patients. And so there had just been kind of our regular level of the large heart attacks that we called STEMIs, and we've had this regular level at our medical center, maybe 15 to 20 patients per month having a heart attack that we have to take to the cath lab emergently. And we noticed when the pandemic was in full bloom that almost came to a screeching halt. And then via social media and going to talking to colleagues, we started to see that was a national phenomenon. And so it made us think one of two things. We said, well, wait a minute, there shouldn't be anything about a virus that is preventing heart attacks, right? That's more inflammation, if anything, that would cause more heart attacks. So I wonder if people are staying home. And then sure enough, people started publishing about it. And when patients did come in with a heart attack, they would tell us that, I stayed home for a day or two or three. Why? Some of it is because of the messages we were sending out, that if you're sick, don't come to the emergency room because the hospitals are overwhelmed and there are these viral particles all in the air. And so people sadly were staying at home with their chest discomfort. And what we started to see a little bit, and I hope we don't see more, are these very late stage complications of a heart attack. So I lecture to our first year medical students about heart attack, and there are some complications of not presenting early with your heart attack, such as the heart tearing or a part of the heart muscle valve rupturing or the heart itself basically exploding. But when I lecture for years, I've said, now you're not going to see this very often because these days we open up and treat heart attack patients right away. But my concern is that now we've actually seen a few of these late stage complications of late presentation. And so it's really sad. So we've got to be careful about our messages because and I don't mean just my place, as a medical community, we were sending that message out of don't come to the emergency room. And some of our heart attack patients really took that seriously, unfortunately.
So Quinn, I think you tweeted on Monday, and I have to tell you, I was heading into the OR or in between cases or something, and I saw your tweet, and it just made my day because this collage of pictures that you tweeted show us an EKG when somebody's having a heart attack, what the angiogram looks like, what it looks like when you've cured them, and then you being very serious in your celebration. So I'm wondering if you can talk our viewers through what this is and the magic that interventional cardiology can do.
Oh, thank you. So I think it is, I'm partial, but I think it is the best specialty. It is truly a blast. So I'm on social media, as you said, and we use social media for a few reasons. I'm only on Twitter, but we use it to educate. We use it sometimes for humor. We use it to recruit to our programs. We use it to speak out against injustice and simply to get out some PSA. So here in the upper left corner, you have an electrocardiogram that shows someone, if you're not a cardiologist, you may not recognize this, having a very large heart attack. And to the right, upper right, is an angiogram. And there's the most important of the three coronary arteries is completely occluded. And then lower left, this is what it looks like after we've opened it with a balloon and stent. And for years, I say to my heart attack patient, after we get the artery open, their chest pain gets better. I say the heart attack is over. And my staff got such a kick out of that they had these T-shirts made up. And so 1, 2, 3, 4, this heart attack is over. We have fun with that. But if I want to take if I can, I'll take this opportunity to say, please don't stay home. The emergency rooms are safe if you need us. If you're having chest discomfort, call your doctor. If you can't reach your doctor, come into the emergency room. It is safe. We have precautions in place to protect you. We don't want anybody staying home with severe chest discomfort or a heart attack because you're afraid to come to the hospital.
You know, we resumed elective surgery in mid-May, and I do a lot of weight loss surgery as well as some general surgery. And when we started, you know, the hospitals took great measures to try and make sure that the patients would be safe and that there would be virtual. We went for zero transmission of virus. And so far, when we look at the elective surgery schedule at certainly in New York City area, there has not been any transmission. And I actually think, talking to my colleagues across the country, there hasn't been any patient getting COVID from a hospital. And I think, you know, early on, we didn't know what to expect. We only saw, you know, the horror that was going on in Wuhan and Italy. And so we told people to stay home. And, you know, if it was something minor, right? But now we know that we really know how to use PPE appropriately for all of our staff. We know how to protect our patients. And also the patients now know when they come in, if they're wearing a mask and they're doing the social distancing, that they're going to be safe. And I think that is a critical piece to walk away from, especially as some of the states are still sort of surging, which is unfortunate.
Yeah. Mm-hmm.
So I think the elephant in the room this week has been, when do we get our kids to go back to school? And we saw the American Academy of Pediatrics give guidance, and then they clarified their guidance. We saw the CDC give different information. And I'm wondering, Susmita, because this is the talk of the town, we know that it is better for in-person education. We know that it's certainly better for education overall, and we know that it's better in terms of equality, economic equality for education. But can you talk to the parents who are watching, the teachers who are watching? You know, I think all of us have had so many questions. When is it safe? How will it be safe to educate our children in the way that they deserve to be educated?
Yeah, I think, you know, I would say this is such a challenging situation, and everybody's trying to work on pulling together what we know from the science of what we understand. And so, like I was talking about before, the precautions that have been taken by daycare and childcare centers that remained open to take care of children of essential workers who were going into work, like all of us, they took these precautions that were recommended by the organizations, and it's working. That's what we know. And so as we learn more and more about the science of the transmission and the prevention, if schools and daycares and camps, all of those are following those recommendations, that seems to be, the best way to go. And unfortunately, the reality is every time you go out, if you get in the car or you get on a plane or you walk out your door, you're always taking some kind of risk. And we can't live in a bubble. Our children shouldn't live in a bubble. That's not the best thing for anyone. So we have to understand what risks we're all willing to tolerate in order for our children to have the best education they can have and grow emotionally and, of course, cognitively.
I had a patient come in Friday who is a vice principal at a school, and they're trying to figure out how to coordinate technology with in-person learning. So they've got this system that they put up where there's a big screen in the back of the classroom so that if they have alternate schooling days, all the kids get the same information, whether it's virtually or in person on every day. They can communicate with all of the children. I feel if we have enough money to bail out huge corporations, we should have the money in our country to help schools fit technology, HVAC systems, security, and salaries for our educators and our staff so that we can, in fact, provide the best education. I wonder if people are doing things like that or hybrid things in the neighborhood that could be something useful.
Yeah, I think schools are trying all kinds of things. They've all been trying hybrid, and that goes from everywhere from, the preschool age all the way through higher education, college, medical school. And so, of course, there are some things you have to do in person. We can't teach how to do surgery virtually. It's not going to work entirely. Of course, we have really sophisticated ways to do simulations now. And that's a great way to train, just like pilots do simulation for flying airplanes. So there's definitely a role for technology. And the question is, where's the sweet spot? So, it's really something that I think we're all learning to navigate and learning what works and what doesn't work. And as we learn more, then we're going to share best practices. So I think, it's, again, a very tough thing. I'm certainly not the one to make policies about this kind of thing. At the same time, I 100% agree with you that we need to invest in our children. They are our future, and that means investing in education.
And, a lot of everyone, as you said that, in-person learning is so important for kids. There was a comment now from Stu Schimmel who said, that he feels it's not going to be safe because look at the camps that have opened. And I think he's referring to that one in Missouri where there were 82 people from the camp that ended up getting infected. And, I have friends that are sending their kids to camps that are 8 people, or 8 kids in a session or in a group, and not the larger camps or larger group sizes that they have had. And I'm sure you're seeing that, Susmita, out in Long Island. And I don't know, Quinn, if you're seeing that as well, if you have kids that age that are going to camp and what the situations are there. But it is a concern, that teachers themselves, one thing with the camps, you're outdoors. That's the whole idea, right? That's safer. But when you think about, New York City is putting out a blended pattern for the fall, right? 3 days in class, 2 days out. My girlfriend down in New Orleans, her kids are also essentially in every other day class, and the other day is at home. It's complicated. I know all the colleges and universities are going through a process of trying to figure it out. But what are you guys seeing with camps by you?
So if I can speak, so I wanted to talk about something just because I don't want us to forget it. Now, I worry with school and what in the world we're going to do with school and pandemic. I worry with the online, the virtual classes, I worried about the digital divide, the fact that not everybody has access to the internet. Schools have done some creative things to make sure that children are not left behind. Like I know at some communities here, they'll put a school bus with the big Wi-Fi router on it, and kids then can get the Wi-Fi access. But I really worry about the gap in achievement between some students who may be from a disadvantaged background and those who are from an advantaged background, that gap will get even wider. And if I think about even classes that I had difficult with in college, in the 45 minutes in class, that was one thing if I really didn't understand what the professor was talking about. But I learned that at night by going over the material again and again and again. And so if we have students who don't have access to the virtual material, or they only have access to it, during the daytime, then I really worry that they're going to be left behind. So I'm very concerned about that, and that in the conversation about schooling and about virtual online classroom, we can't forget not everybody has at least easy 24-hour a day access to the internet.
Yeah, Quinn, I 100% agree with you. I think, this is definitely a concern that I share. And I think it comes back to how are we going to invest our dollars as taxpayers? And are we going to invest them in supporting the closure of these gaps so that everyone has the access to education that they should? Public education is designed to level the playing field. And that's sort of the whole idea behind it. So we sort of need to think about that as a society and as a group. There's no easy answers, right? You spend money on one thing, you got to choose not to spend money on something else. There's not an infinite pot of money. So so these are not easy things to answer. Of course, as a pediatrician, I would always say vote for kids. That would be my mantra.
Well, I would say, general surgeon, that I completely agree with you. Vote for kids; they're our future. So, I think all of us would agree. Hopefully, that's the key. I also think it's kind of the dark, funny side about all of this is that we would tell the kids, screen time decrease right now. It's too much screen time, and now we're like, well, listen, you got to get on your computer, and you got classes for 7 hours. And my friends would tell me some of their kids and patients as well, were on the screen for 7 hours. They actually had scripted classes for 7 hours. I mean, that is so hard. After one Zoom call, I'm exhausted, and you can't even maintain your Wi-Fi for one Zoom call half the time. So it is sort of, it's a very difficult thing, I think.
Yeah, I mean, all the studies about screen time are somewhat, mixed, right? So to some degree, it depends on what people are watching and what they're doing. Definitely using a screen to communicate takes a lot more brain power because you're not in the same room. You can't have the body language, the cues, all of those kinds of things that you do have when you're in person. So it's definitely harder. It takes more effort. And so again, how do we figure out what's the best way to use these technologies that's not going to compromise and could potentially enhance our children's education?
So I think one of the points that our listeners, our viewers are making, Sujana Parekh says, what about our teachers? Many are over 60, many can be immune compromised. I know my kid's favorite high school teacher managed to go through cancer, chemotherapy, and still keep teaching history. So we have an obligation to our children in the society. We have an obligation to our teachers. I think that this pandemic is really opening up significant concerns about inequalities throughout the system. But I'm going to switch gear because we've only got about 15 minutes left with these amazing guests, Dr. Quinn Capers of The Ohio State University Interventional Cardiology, and Dr. Susmita Pati of the Stony Brook University in Pediatrics. So please write in your questions, write in your comments. We'd love to answer more. But Quinn, you talked about if you're having chest pain, don't hesitate to come into the emergency room. We know that women have different types of cardiac symptoms than do men. And we actually know that women come to the ER with cardiac issues, but odd symptoms, and they're sent home, let's say on a proton pump inhibitor or something like that. So I wonder if you can talk to what women should be looking for, or what people should be looking for if their female relatives are having chest pain. What necessitates them going to the emergency room?
Yes, so thank you so much for bringing that up. In fact, I used chest pain, but what I should have used is what I usually use in my patient encounters and what I teach my trainees to do, and that is chest discomfort. I learned the hard way once when questioning a patient over and over again over a number of weeks if he was having chest pain, and he kept saying no, and then he wound up in the hospital on the day I was off and he had a heart attack. I went and peeked at his chart, and his chart said he'd had months of angina. And I went and talked to him, and I said, well, I've been asking you every day if you were having chest pain. He said, well, yeah, you asked me if I had chest pain. I didn't have chest pain. I had chest pressure. And so now you almost have to be a little bit of a detective. So we ask about chest discomfort. The most common symptom of a heart attack is an uneasy discomfort in the chest, pressure, heaviness, tightness, squeezing. However, those are what we call the classical or typical symptoms, but there are unusual or atypical symptoms. There could be back pain, shoulder pain, profound fatigue, breaking out in a sweat. Sometimes it's in the jaw. I've had patients who thought they were having a toothache when they really were having a heart attack. And it turns out, for reasons we're not clear we understand, that women tend to have a higher proportion of those atypical symptoms of a heart attack than do men. What I like to say to people is know your body. Whatever the ache or pain is, you know your body, and you know we all have, I think most of us, our usual aches and pains. But if there's something going on, a stomach ache, your shoulders are hurting, you're more short of breath, you are sweating and you can't figure out why you're sweating, that's a reason for you to, if you can reach your doctor quickly, call them. And if you can't, come into the emergency room. And then we need to do better and better, and we are getting better, about training our healthcare providers, our physicians, our students, residents, fellows, that women and the elderly and persons with diabetes are more likely to have these atypical symptoms of a heart attack. So have a high level of suspicion.
No, and thank you. That is true. And I know this is something that we were taught in medical school, but yet, and we all went through that same teaching, right? But when we go to the ER and someone comes in, there is a sense of, because it's atypical, that it's not as classic for chest pain. And, I'm not sure if that's, as you say, there's no clear reason why. Obviously, it's mainly because women are having atypical symptoms, but it can also be what the patient tells you they're experiencing. Like, oh, I just have like a little burning or something. And you think, oh, it's definitely not a cardiac event. But, the age is important. Family history is important. I think that thankfully many of our colleagues get it when they're interviewing these patients when they come in. I had an interesting question from actually a couple of weeks ago that talking about if you have patients that are reckless or not following social distancing, not wearing a mask, engaging in high risk behaviors like that whole Lake of the Ozarks, big party. Should insurance companies not pay for those patients when they come in? It's sort of the same thing as smokers and other things where actually smokers do get covered. But can a medical system or a physician actually say, we're not going to take care of you? I know the answer, right? Because we always do take care of it. But it is an interesting ethical question about whether, if you're completely not following any of the rules, what should happen?
Yeah, that's a really challenging question. And in our society in the US, it's a recurring question because healthcare in this country, of course, everyone behaves as if it's a right. If you get in a car accident, you expect to be taken to the emergency room and taken care of. If you get sick, you expect to go to the emergency room and get taken care of. The reality is that healthcare in this country is funded as a privilege. So not everybody has healthcare coverage. We don't have universal healthcare coverage for everyone. And people who have certain types of insurance coverage have, more available to them than others. And those disparities, certainly in financing, certainly have implications for how things fall out in when healthcare is delivered. So it's a real challenge. It's a very tough question. Again, this is not something that has an easy answer. And I think we're going to see more and more of this discussed, of course, as we enter the election this fall.
Yeah, and if I could simply say this, as you said, Marina, on our end, doctors, we're going to take care of everybody. If you're in need, you come in, we're going to take care of everybody. But boy, it's a really great question. It's a good question, really, for an ethics class in terms of whether or not an insurance company can or should deny. But I can tell you, I would not want to practice medicine in a world where someone's in a car accident, they injure their head, and then the insurance company can say, well, you didn't have your seatbelt on, so we're not gonna pay for the care that you need for your head injury. I understand where the question comes from. It's a deep ethical and moral discussion. From my perspective, as a physician, if you need help, I'm going to help you.
Yeah, and I think that has to be that way. We actually faced some of that and fought it down in New York State because insurance companies were not covering trauma patients if there was any hint or suggestion of there was alcohol on board. And so the hospitals were getting stuck with these tremendous bills. So it is a complicated question. We should move on. I know Sujana has this great question about writing and communicating. I'm glad it was her and not me that this happened to, but Suju, please.
So I just want to alert our viewers, not only are we talking to two outstanding clinical physicians, but really we're talking to people moving the needle way forward, both in diversity in healthcare and in communicating important subjects. So I think I'm going to address this to Dr. Pati, to Susmita. So I have a friend who's an amazing writer. He actually writes for Forbes magazine. And I've had him read a couple of the things I've written that have gotten published in our journals. And he literally has asked me if doctors are taught to write poorly. He can't figure out what I'm trying to say. And I'm like, those are the words we're supposed to use. So how has your work over at the ALDA Center for Communicating Science helped you teach us how to distill information in a way people can actually understand it?
Yeah, sure. Well, I think I want to back up a little bit and tell you why I decided to join the ALDA Center. So I've had the opportunity now over the past 20 years to work in 3 different academic medical centers. And I've had the privilege of working with really talented folks in multiple disciplines. And what I have learned from all of those experiences, whether we're working on a project that's trying to make clinical care better, advance research, or medical education, is that communication is fundamental. Really good communication is fundamental to success in whatever project you're trying to undertake. And that was really what motivated me to join the ALDA Center team. And I was really honored when they asked me to join. And the communication issues in healthcare are, of course, critically important. And we're trained really well to communicate in emergencies, in a code. Someone comes into the hospital, like we're talking about the emergency room, who's having a heart attack or a victim of a severe car accident. We do really well at that communication. We know who's doing what each person's role is, and we know that based on where they're standing, all of those kinds of things. Where we don't do so well and where we can improve is all the rest of it. There's a lot of gray area, right? When everything from, rounding every day to talking about, what are going to be our quality improvement metrics that we're going to set, what's the best way to educate our trainees, interdisciplinary research. And that's where we can really make a difference and move the needle. And so we've been really having a great time with the ALDA Center folks in figuring out ways to leverage improv theater techniques to improve communication skills. And that's been a lot of fun.
I am a tree.
I'm a true. You're too much. Can we talk about some of your efforts at The Ohio State and the Medical Center, and how you have improved diversity, inclusion, what the programs are that you've helped get started?
Well, thank you very much. So we fighting to reduce or eliminate healthcare disparities is a big passion of mine. And when you think about healthcare disparities, like the example that I gave earlier, there's so many potential culprits, which means that we need everybody working on different levels. So I like to think of it as a team. There's a team of people, and every person on a team has a different role. And what wonderful colleagues I have at Ohio State and around the world. And that includes all of you ladies on this call. But everybody has a little bit of a different role. Some people are trying to attack social determinants of health. Some people are trying to attack healthcare financing. The way I see my role is in helping to diversify the physician providers. And for 10 years, I was the dean of admissions in the medical school at the Ohio State University. And we made some great strides, and now one of the most diverse majority medical schools in the nation. Some of what we did was come up with a mission statement that values diversity. We also adopted this concept of holistic review when evaluating medical school candidates. That comes from the Association of American Medical Colleges, but we were early adopters. And that is looking at more than just the grades and the standardized test scores, but looking at the whole person when you're deciding who should be let into medical school. And also implicit bias. We all have these unconscious biases about race, gender, height, obesity, attractiveness, etc. And it's true that you might think you're being a fair person and that you have an egalitarian heart, but you actually might be treating people differently based on how they look. And that includes interviewing people for medical school or residency or fellowship. So one of the things that we innovated was having our admissions committee take implicit association tests to find out what are their biases, and to have every single year implicit bias mitigation training. And so those are some of the things that have led to us being a town or school that is really kind of a champion for diversity. So we're proud of that, but it never ends. You have to be ever vigilant and ever working to diversify medicine, because right now the physician workforce in the country doesn't come close to reflecting the diversity in this nation. And we need to get closer and closer to have better care and to reduce healthcare disparities.
I couldn't agree with you more. I love that you said you had to take an exam to reveal your implicit biases. I mean, that's really fantastic. Of course, we all think we don't have them, but we 100% do. And I've interviewed medical students for residencies before, and there's certain people you jive with, others that you don't. You don't like something about the way they're carrying themselves. So there is so much that can be done to improve that. And just real quick, remember when they did blinded auditions for, like, these orchestras would have blinded auditions for people who wanted to join, and they kept, when they didn't do it blinded, they'd pick more of the men. They didn't give the women a chance, and they didn't hear what they were playing. But when they blinded them, every single one of those auditions, there's this one particular case I'm thinking of, the woman was chosen. So it shows you that when we look at somebody, our thoughts can go to what we're seeing instead of what they're actually saying to us. So that is definitely bias.
Yes.
I think we're out of time. And I want to thank you guys.
I think we are. It has been so great. We could talk to you forever. I think we're seeing more people of diverse backgrounds come into leadership. I hope that a show like Marina and mine highlights these amazing, amazing individuals that people should get to know and follow on their social media platforms. So I want to thank you, Dr. Quinn Capers, the fourth MD from The Ohio State University, and Dr. Susmita Pati from Stony Brook University. Thank you so much for joining us today. We're going to do a little housekeeping. Marina, maybe you can thank our staff, and we can introduce next week's show. But thank you guys so much for coming on board with us.
For joining, and all of you guys watching, thank you. But stay tuned, because we're going to show you what our next week is going to look like. But first, I'd like to thank, here we are, next week, Dr. Wendy Cinta. She's the former president of the Obesity Medical Association. She's going to be joining us. and Dr. Tamara Fountain, who is the, she's an oculoplastic surgeon and past president of the wait, is she past president? But anyway.
President-elect, actually.
President-elect of the American Academy of Ophthalmology. So we have two great guests, and I want to thank our team, and these are our producers, and this is the people who really give us the ability to put this together so seamlessly, and definitely want to thank our viewers. Sujana?
So thank you guys so much. Thank you Scroll.in for hosting us on your platform. Thank you for our production team. Thank you to Marina, who always keeps me on the straight and narrow. Next week, not only will we be talking about eye care and obesity, but because the 4 people on our show, the 2 of us included, are leadership in our medical societies, we're going to talk about leadership and particularly the roles for women in leadership. So we really hope you join us next week. Keep sending in your questions and your comments, and happy birthday to my mother-in-law, Lakshmi, and my sister-in-law, Shanti. I'm very proud to be part of your family.
Oh, that's sweet. All right, you guys, thank you so much for